I'd like to go ahead and introduce Debbie Cestaro-Seifer, who is here to present our talk this morning in the webinar. Debbie has a diverse background which includes nursing research, psychiatric and pediatric nursing, which is where the emphasis of her master's degree is, and she is a former college professor. She's worked in HIV care for the past 11 years. And currently, Debbie is the project coordinator for the Florida Caribbean Telehealth Education Training Center, and she serves as a clinical educator for the Florida Caribbean AIDS Education Training Center.
The learning opportunities that I've prepared today are very active, hopefully the types of learning opportunities that we partner with our patients when we're working with them to facilitate their understanding and self-management of care. I'm hoping that at the end of this program you'll be able to explain the chronic illness disease cycle, describe the overall secret of motivational interviewing, identify the 6 stages of change according to change theory, recognize change talk and sustained talk in patient communication, and lastly, identify the 4 core communication techniques and their role in working with patients to facilitate change. We're going to talk today about building patient partnerships, building successful partnerships using motivational interviewing as a strategy. To begin with, I'd like to share with you, well, probably everybody on this call is engaged either in acute and chronic illness care and treatment, one or the other, or we may be lucky enough to have you working in both areas of care. But I put this slide here for you to show that even with acute illness, that is for short-term illness, we still can use motivational interviewing. And in chronic illness, most definitely, we can use motivational interviewing as a strategy in working with our patients, because when you are ill, there are critical moments in working with your provider on health management, with health education as the forefront, and health prevention messages that hopefully promote wellness. When we work with someone that is has chronic disease, as a provider, let's put ourselves in the provider role, we're thinking with this new patient, what are those physical symptoms they have? What facts about the disease do they need to know to understand what's happening to them? What skills do they need to manage their health-related problems? And what behaviors we know will help them get through living with a disease that is chronic and hopefully give them a high quality of living. And lastly, we know what strategies to teach patients to promote healthy living. Now we're going to put on our patient hats, and we've all been a patient at one moment or another. So we're going to now look at the patient. The patients are coming to us, especially those that have a chronic illness, and they want to know why they don't feel good. They want a solution, and in most situations, they want a quick solution. They're not used to having a chronic illness, and so they're not used to having something that lingers, that can't be fixed. We tend to be in a society of instant. We want instant weight loss. We want instant, if I have a headache, I want to be able to take some sort of ingredient that will take my headache away so that I can get on with my life. So I want it fast and I want it to be effective. I have disease beliefs as a patient that I come to, that I learned as a child, that I might have learned from family, friends, and those beliefs come with me at that appointment when I am learning about what these symptoms mean and why I'm going to have them for a long time. The other thing I'm coming to as a patient is I want to know what it's going to take me to have a normal life, because quite frankly, as a patient, I want my normal life back. I'm not sure of this new life, and I want the symptoms to go away so that I can be normal, like I was before these things happened to me. The other things that I'm coming as a patient with, I'm coming with frustration, fear, depression about what it would be like to have these symptoms for the long ride of life, and I have fear of the future. I don't know what the future brings. So as a patient, I'm coming with a quite different set of questions, and the provider, as a provider, we want to be well aware of our patient's situation and how they present to us. The chronic disease symptom cycle is something that I show very briefly when I talk about motivational interviewing, because when you're working with someone with chronic disease, there is a vicious cycle of having symptoms that can't seem to be resolved, and that causes anxiety, which anxiety causes tension. Then we start to get pain because our neck and parts of our body start being overly worked out because we're so anxious and we're holding our shoulders tight. We may be holding other parts of our body very tightly. Causes more stress and anxiety because suddenly now we're having pains we've never had before. And then we get, quite frankly, very depressed because we don't see an end to this. Where's the resolution? It may even cause, in some cases, shortness of breath and serious fatigue, where patients start to say, there's nothing to do. I'm going to be stuck in this situation for a long time. So psychological stress is, as a result of chronic illness, is a situation that as medical providers we need to be very aware of, and we often are, because we know our patients have medical uncertainties, financial uncertainties, personal uncertainties, because we don't know how our life is going to look, and certainly we have social uncertainties, especially when we have an illness that may be seen by others as being stigmatized or something that would require other people to treat me different. Not that we want people to be treated different, but that there may be a reason why people might try to not treat me as I was when I was normal. So again, there's a lot of uncertainties when an individual is presenting with a chronic disease. And these symptoms that they show us are oftentimes insomnia, fatigue, anxiety. They're depressed. They may start to socially isolate themselves because they don't know how to interact with people given this new diagnosis. And there may be grief, the grief of the old life, the normal life, and this new life. So again, our patients are presenting to us with a variety of symptoms that are often psychosocial in addition to the physical. So the self-management needs of this patient population are huge, and I put them into three categories. One, individuals who are ill, especially chronically ill, have to learn how to cope with intense and sometimes debilitating emotions. Two, they have to learn how to change some behaviors in order to minimize the impact of the chronic illness in their life. And lastly, they need to manage the disruptions that the illness and the treatment may cause work, school, and family. So a potential outcome of chronic disease can be seen by many of us in healthcare, and that is a patient that becomes, as I call them, unplugged. They don't know what to do, and so doing nothing becomes the order of the day. And this is not how we want to see our patients. And when we have many patients that are faced with chronic illness or symptoms that they don't understand, and they are not getting those symptoms resolved, we become unplugged with our patients. And we start to sometimes lose our ability to be upbeat and focus on the individual needs of our patients. So there comes the partnership. How do we develop this partnership that isn't one of telling patients what to do, filling them with information? Take your meds, take every dose, stop doing drugs, use condoms, exercise, get your labs. I think you've all heard it. We've probably even said it a million times as providers to our patients. This doesn't look like a partnership to me. And I hope as you're viewing this in groups or by yourself that you envision that this isn't going to be the best partnership for especially a long-term professional patient relationship. Now this picture here emphasizes the partnership, coming together, working together, because it's the patient that eventually goes home and has to manage their own disease. So how do we partner with our patient to help them be the best they can be? What behaviors promote this engaging partnership that I'm suggesting and talking about? Well, feeling welcome, feeling comfortable, feeling understood, feeling that the staff and your providers have exceeded your expectations, having mutual goals so that when you're sitting there in the office together or in the clinic room, that you're talking about the same thing and you're both on the same page. And last but not least, being hopeful. So I look at this engaging partnership we develop with our patients as growing a beautiful flower in a garden, and hence the picture here of seedlings growing. So as providers, wow, we've got quite a list of things that we need to be on top of in working with individuals, especially who have chronic illness. And we have to have a toolbox for how do we test, how do we screen, how do we address medical adherence, medication adherence, how do we help patients stay in care so that they can stay as well as possible and be a part of new therapies. How do we facilitate transitions from one provider to another when patients move or have life transitions? We have to have a toolbox. And when we effectively partner with patients, we have to have knowledge of the disease process. We have to be comfortable in talking about the disease. We have to understand what screening and assessment tools will assist us in the care of our patients. We look for communication and counseling techniques that will help us build this partnership from the ground floor sometimes. We look for quality care planning tools, and we look for quality improvement in the care of our patients who are living with HIV or any other chronic illness. One of the tools might be knowing how to take a sexual history, which is something that I think everybody on this call would like to be comfortable in that. And so I recommend the 5 Ps of sexual health that HRSA recommends, and that's partners, practices, protection from sexually transmitted diseases, the past history of STDs, and prevention of pregnancy. Sometimes just of us having these tools in our pocket or somewhere on our desk reminds us how we approach patients to have these very important but sometimes very delicate discussions. Screening tools that detect psychological distress. We have to have tools that work, that make sense, and that don't take a lot of time. Screening for stress, grief, depression, frustration, insomnia, anxiety. 2 tools I could recommend here for perhaps providers that are working with children and adolescents would be the Children's Depression Inventory. They have a short version, the CDI-2, and I've put the references here for you. Another tool that is about anxiety in children is the Penn State Worry Questionnaire. Again, we've put it in a word that children understand, worry, and questions that the children are answering on this tool are, do you worry about things a lot, or don't you worry about things a lot? Do you have trouble sleeping because you're worried about things? These are some nice tools to use in the clinic setting, and some of them have validation, meaning that the parents and maybe a teacher would also fill out that tool so that we can get some sort of understanding of how the child is seen by the parent and the teacher perhaps that know this child very well because they spend so many hours a day with the child. So again, just some tools for you to have available when you're working with different populations. So now let's talk about motivational interviewing. How does that fit in? Well, that's a very important piece of that, developing that big important partnership. And if we talk about motivational interviewing, we cannot miss the opportunity to talk about health behavior change, because motivational interviewing is about facilitating health behavior change in our patients. So I'm going to ask you for a few minutes to close your eyes for a second and think of a behavior that you tried to change in the past. Might be something very simple, like taking the garbage out once a week to the end of the road. Sometimes just simple things are hard to do. And then, did you ever feel ambivalent about it? What does that mean, ambivalence? Well, ambivalence is a big word, and our patients often don't know that ambivalence is a part of change. Ambivalence is thinking or feeling 2 ways about something. Part of you wants to do it, and part of you doesn't want to do it. You can find good reasons to go about maybe taking the garbage down to the end of the road for the garbage man to pick up, And you can also think of good things that it might not be in your best interest to do that. Maybe you've got a bad back. Maybe that garbage can is really, really heavy. And maybe you don't fill it up every week, so it doesn't make sense to bring it every week to the end of the road. The contemplation stage, this is a stage of change. This is where ambivalence rests. You're thinking about changing. You start to be thinking about those things that would facilitate change and those things that might be barriers to change. Ambivalence is normal, and it does get people stuck, but it is a very positive piece of the change process because it allows people to look at both sides of the story. So here's my visual aid on stages of change. And notice that I have the first stage of change called pre-contemplation. I have it outside the circle. Many of you may have seen this in previous maybe work that you've done in school. Pre-contemplation is often on the circle, but I took it out, and I'll tell you in a few minutes why. So the first stage of change is pre-contemplation. The second stage is contemplation. Third, preparation. Next, fourth is action. You see the little man running, the little person is running. They've got action. They're doing something. Maintenance, there's a toolbox. We've got to have the tools to keep on the same road. If we've made a change in our health behavior, we've got to have tools to stay in that spot and keep doing that behavior that we changed. Then you have that last stage, which is relapse. I call it the bump in the road, when we suddenly find ourselves following an old behavior pattern. So these are the stages of change, and that pre-contemplation is all out there by itself. I wonder what that means. Well, it means for us that are working in motivational interviewing that the patient isn't shopping. They're browsers. They're really not interested in making the change. And I know that you know what I'm talking about when I say many patients come to us saying, I'm not going to do that. People tell me they want me to quit smoking. People tell me I should take my antiretroviral therapy. People tell me I should use condoms. People tell me I should take my medicine, but I'm not doing it. And I want you to stop talking to me about it. I'm not coming here to talk to you about it. This person truly is not shopping. And so we sometimes will work with the patient like this and start telling them all the reasons why they need to make a change. And because they're not shopping, they're probably going to get a little irritable. And so they get resistant. And so we get very tired with patients like that because we don't know what to do. We get stuck. And we see them as perhaps a problem patient. We see them as a patient that's unwilling to address their issues. But I'm hoping that throughout this program today that you'll be able to reframe that resistant patient and look at them in a non-judgmental way and start to look at them as someone who's just simply not shopping, but we still have other things we can be talking about. So let's do an activity block to see if we all are on the same page. It's called Debbie's Name That Stage. All right. What we're going to do first is ask, according to the stages of change model, individuals in the pre-contemplation stage would say which of the following? A, don't even talk to me about using condoms. B, I'm thinking about using condoms. C, I am getting ready to use condoms. Or D, I used my first condom last week. Pre-contemplation is don't even talk to me about it. And yes, that is where we are when we're in pre-contemplation. The person that says I'm thinking about it, that individual is in contemplation. They're starting to think about the process. Now, they're looking maybe at more barriers and more supports to doing this new change, but they are thinking about it. They are shopping, okay? So they are on the circle. The answer to that one, pre-contemplation, is someone that says, don't even talk to me about that. Here's another one. Let's try this one. Name that stage. I've been using the stuff I learned in group so I don't get so angry at home. I haven't gotten angry in a while and my girlfriend seems happier. I think I'll keep this up. Is this individual a pre-contemplator a contemplator? Are they preparing? Are they in action? Are they in maintenance or relapse? What are your thoughts on this? Those folks that say action, yes, they're using the stuff. You see that action word. They're doing something. This person was probably most likely in an anger management program, and they were given some strategies of how to deal with anger management, and this person is using those strategies, and they even like them. And there is a value in it because this individual is saying, I haven't gotten angry in a while, and my girlfriend seems happier. I think I'll keep this up. The key word in locating where this patient is in the stages of change is, I think I'll keep that up. They're truly in action, and now they're in maintenance. This is someone that is in maintenance, and they're making a commitment to you in your office that they're going to keep this up. So that's an exciting moment because I want to clap for this patient. Okay, they see value in these strategies, and they're getting positive reinforcement for it. Now, is this a patient that I would say, oh boy, well he's or she's got this down now. No more work in this area. Let's pick another subject, to a health-related topic to work with this person on. No, because maintenance is a stage where people can hit speed bumps. So on this patient, I have said in the past, and this was a real patient for me, I asked this patient, tongue-in-cheek, using a small amount of humor, said, okay, well, I'm thrilled, and I'm excited for you. Congratulations on your commitment today. But let's just, what if? What if your girlfriend had your car running, and it just so happened that she didn't have the emergency brake on? And unfortunately, while she was running in the house to get something she forgot, the car or truck went backwards over a cliff, and it was your car or your truck. How would you feel about that? Well, needless to say, that is a role play. That's an opportunity for me to hear from my patient that perhaps there are new things that they could learn, or that perhaps something could happen that could set them off where they would hit a speed bump, and the strategies they learned for anger management might no longer be effective for them. And so, again, constantly working with our patients to say, okay, well, still food for thought, still more work to do, but good for you that you've gotten this far. And let's maybe do some role play about what you would do in some really advanced situations that might require a lot of your patience. Here's a last one. Name that stage. My dad is exaggerating. I'm not using weed that much. Where is this patient? Is this patient in pre-contemplation, contemplation, preparation, action, maintenance, or relapse? Let me emphasize a word, and let's see what you think of this. My dad's exaggerating. I'm not using weed that much. Ooh, that changes it a little bit, doesn't it? Yes, I would agree with the pre-contemplation, but when I say the words that much, I feel a sense of contemplation. I believe that this individual may have thought, ooh, perhaps I have overused my weed at times, but in this situation, I think my parent is being unduly, overly excessive about their concern. But I believe that this patient may be contemplating a little bit. Now, would I go to this patient and suddenly say, aha, I got you. You are thinking you're using too much weed, or that weed is bad? No. I would very subtly try to discuss the issues about, well, I wonder why your father's so concerned, and it sounds like he may be excessively concerned. What do you know about what weed does? Those kinds of questions. But I wouldn't go in hardcore with this patient because, again, I'm trying to engage in conversation, and I'm trying to evoke the client to think about what he just said. Because everything in motivational interviewing is about helping the patient to listen to what they say, what they feel, and we simply facilitate the process. So how do we recognize change talk? Well, let me give you some modifiers that will help. When someone is desiring to do something, you may hear, I want to take my meds. When someone is showing ability, I can. When someone is starting to have a reason for something to change, they'll say, it's important. If someone's displaying, perhaps they understand there's a need, if I do this, then that's telling us that they're starting to have an understanding of that change might be in their best interest, or at least that they should consider making a health-related change. Other examples might be in terms of commitment, activation, I'm ready, and taking steps, that action phase. I'm trying to figure out what the best plan so that I can become a non-smoker, or I'm trying to figure out what the best plan is for me so that I can use condoms with my partner all the time. Again, recognizing that change talk, I hope that these slides will help you in that recognition. Now, we also need to recognize sustained talk. Sustained talk is when someone is maintaining the status quo. They don't really want to make any changes on a particular health issue. So you're going to hear things with sustained talk like, I'm not going to do that. I don't have that. That's not possible. I have plenty of time. I'll do it when I'm 50 and the person is 13. I can't take those meds all the time. I need a break. That's sustained talk. They're trying to maintain the status quo. And it's our job to help them hear themselves and find out, maybe learn from themselves why they want to maintain it. What are they gaining from maintaining it? And what could they be losing? We as providers often find ourselves when a patient seems like they're not contemplating something that seems so simple. You know, if you're using 8 liters of oxygen and can barely breathe getting around your apartment, it would make sense that you would think someone would want to quit smoking. But that's not always the case. And instead of the righting reflex, which oftentimes as providers we will go into, we want to fix, we want to make it right, we want to heal, we want to prevent harm, we want to promote well-being. We say, well, you've got to quit smoking. You don't have a choice now. You can't breathe. But again, we're trying to right something that a patient isn't shopping for. So what happens when we tell someone what to do, my experience, is they do the opposite. They get tired of me, they tune me out, and they don't come back for care, and they become very disengaged from me. And I can tell just by the fact that they're either not showing up, or when they come, they don't have very much to say, and they want to just get in and out of my office. So what is motivational interviewing? This is the meat and potatoes, as Millie said, of this program. It's a method of counseling. It's designed to facilitate the natural change, the patient's internal motivation, not our motivation to have them change, the patient's motivation to internally change their status quo. Motivational interviewing is a goal. It's a goal to increase internal motivation to change by addressing an individual's ambivalence to making those changes. The premise of motivational interviewing is that confrontational strategies are not effective. We don't want to wrestle with our patients. We'd rather dance. And it's based on the stages of change model, which you have probably started to get a good feel for from the previous slides. Okay, so the spirit of MI. I'm going to tell you that it's positive, and I think you can probably tell that. So what's positive about that? Why would Debbie put FedEx here on the slide? Well, looking at this slide, it takes a while. Don't feel bad if you can't find it. But in this slide is a positive motion. There is a white arrow embedded into this logo. I use this slide to remind us, one, that MI, motivational interviewing, is positive. I also show it because I want us as providers, I want us to remember that it takes a while to see something. And sometimes there's one person in a room out of 50 that will say, oh, Debbie, I see the white arrow in FedEx. I see it. And the rest of the room is going, I can't see it. And some people can't see it after 3 minutes looking at it, and they start to get upset with themselves and frustrated. And that's the way our patients are. Sometimes they can't see something. And we have to work with them and help them witness all the things that come with being frustrated and keep supporting them and saying, you will find your way. You will find the recipe that works for you with this particular healthcare challenge. And that's why I use this slide, because it's a great activity to remind us that sometimes we all don't see what's right in front of us, even if we have 8 liters of oxygen that is going into our nostrils. We don't see it, and it's sitting right in front of us. So MI is about avoiding prejudgments. The strategies of MI, it's a clinic culture. It's not just what one provider does, it's what the whole culture of the clinic does. I've gone into clinics. I'm a mystery clinic shopper, and I oftentimes will go in as a patient, and I will learn what it is, what it feels like to be a patient in a facility. And things that I've heard along my many years of travel have been, oh, here come the dregs of society. Those are the worst patients ever. Why do the worst patients ever have to come to our clinic? Those people, oh my gosh. And we always get the patients nobody wants. This is about turning that culture around. Even if you're the best motivational interviewer on the planet, if your culture, your clinic culture is of, oh, we've got the worst patients, our patients are so difficult, then it's going to be really hard to use motivational interviewing and have patients feel good about themselves from the minute they walk in to the minute they walk out. The other prejudgment is that cultural awareness we need to have. Just because we think we understand what a particular culture, how they see or view healthcare, we don't always know. So we want to check in with our patients. We want to check in with cultural groups that we can speak with so that we understand better what may be the barriers and what might be the opportunities in working with certain cultures for health promotion. We want to match our words to match the patient's ready to change. So when a patient is demonstrating that there is some contemplation going on, we want to match what we're saying to meet that. We don't want to go too far ahead of them. Yes, we have a lot to do in a day, and we have very little time to spend with our patients. So we want to go sometimes faster than our patients. And I just hope that you'll take away from this program today in pulling back the reins and trying to go at the patient's pace. The strategies are explaining to a patient what ambivalence is about, explain that ambivalence is normal, and suggest to the patient that maybe the recipe they're using to make a particular change is what's wrong, and that it's not that they're wrong. They're not bad. They're not the failure. They're not the problem. I say to my patients, well, I think we've just got the wrong recipe. You've been using maybe a recipe that's not working. So how do we make new blueberry cobbler? How do we make brownies? Let's find out how you're going to make this particular healthcare change using a different recipe, because you know what doesn't work. Let's try to figure out. Let me help you figure out what does work. What do you think will work next? Again, a different philosophy, a different focus. Remember, ambivalence is very important in change, and there are different roads to successful change. And I believe this slide demonstrates that for sure. The core components of motivational interviewing are listening, expressing empathy, developing discrepancy, avoiding argumentation, rolling with resistance, and supporting self-efficacy. We have to be safe when we talk with our patients. Our patients are disclosing some very important things to us, very, very personal things, and we have to let them know that those personal things stay with us, that we witness them with them, and we support them, that they don't go further than the healthcare team. They stay in the office and not back out to the community. We also make it safe for our patients to talk to us about behavioral changes by offering them opportunity, promoting self-confidence, helping them with skills, practicing skills right there in the office. The resources that we use to assist providers to help patients optimize their health outcomes are how to use motivational interviewing, and that sometimes takes on-site work with staff to get good at using these techniques. Also, considerations for providers that are on the call today. You'll want to know the level of language literacy, the level of health literacy of your patient population, and how culture affects your patient's health behavior. Why use MI? Well, I say it gives the patient opportunity to discuss other options. It honors patient autonomy and self-determination. It's purposeful and goal-oriented. and it allows the provider to practice empathy. We don't want to be in sympathy. Sympathy is in this little figure here. Sympathy, you're going into the quicksand with the patient. That is not our role. We are there to facilitate the patient learning to live with whatever health challenges they have. When you are in apathy, you're not paying attention. You're saying, oh, it's that patient, it's those patients. When you're in empathy, you practice and tell the patient, this is tough for you, I get that, and I'm trying to help facilitate new changes, new opportunities. So the spirit of MI, the summary, it's collaborative, it's not prescriptive. It honors patient autonomy. It evokes from the patient more information than we are telling the patient. We have to be willing as providers to suspend our authoritative role. We're not parents telling children what to do. I even use this technique with children because children need to have tools so that they can become effective and high-functioning adults. So on issues that we can give children choice, I use motivational interviewing. Providers also need to have a willingness to explore patient capacity and a genuine interest in the patient experience. So there are 4 processes of MI, and there are communication skills and counseling skills that go with it. The 4 processes of motivational interviewing are engaging, focusing, evoking, and planning. In engaging, we focus on the patient, on their mental health status at the moment they're in the office. If they come to my office and they're literally, visually, and maybe verbally upset about something, I'm not going to start talking about using condoms at that moment. I'm going to try to engage them by finding out what's going on with you today. What I can tell by your demeanor that something is very wrong. What has happened? I'm trying to engage the patient so that the patient will tell me what is happening, what is their experience. When I focus a patient, I'm encouraging the patient to share their thoughts. And I have certain goals that I've listed here for that experience. When I evoke, I want the patient to talk about his or her ideas, the pros and cons of making healthcare behaviors, and I can't get that information from them if I'm talking and telling them what to do. In the planning stage, I want the patient to talk about their action plan and how that action plan is going to translate into homework for the next week, 2 weeks, or until the next time I see them, or perhaps when I call them in 3 days to check in and see how they're doing. The goal is the patient will build the recipe for success, and I will assist them by facilitating and checking in with them to support them through that process. Okay, well, now with MI, you've got to have tools, and we've got OARS, O-A-R-S, which again is an acronym. Let's find out what that means. OARS means open-ended questions, affirmations, reflections, and summaries. It's about communication. You don't use OARS or these techniques only with MI, but it is an important part of MI if you're really doing MI the way it was developed. And we have listening, obviously, as a big part of this using your OARS, but look what else happens. Here are your open-ended questions, your affirmations, your reflections, and your summaries. But notice that listening is all over the place. That is the biggest part of motivational interviewing. Well, here we've got Peanuts. So what do you think, says Lucy? Charlie says, well, what difference does it make? You never listen anyway. Lucy says, I was just making conversation. And Charlie Brown says, when you make conversation, you have to listen too. And of course, Lucy says back, you do. So again, just to emphasize that important role of listening. So open-ended inquiry, open-ended questions. Are these open-ended questions? Are you taking your medicines? You drink alcohol socially? You're sexually active, right? Do you use condoms? I'm afraid not. These are not open-ended questions. I call these yes or no questions. Open-ended questions are different. So let's look in this list for an open-ended question. I say that, let's do number 2. How important is it for you to get healthy? That's an open-ended question. That doesn't ask for yes, no. That says, tell me about what you think. And that's where you're building this engagement and this partnership. Another open-ended question, what is your plan and how can I help? Just 2 doors down. What is your plan and how can I help? That's a question that gets a lot of information. You're not going to have a patient just say yes or no to that. Affirmations build feelings of self-efficacy. You want to be sure not to overuse affirmations, but they are very helpful. An affirmation might be, this is hard work you're doing. Your anger is understandable. It took a lot of courage to come here today. Those are affirmations. And again, more affirmations. You have such excellent questions when you come to your clinic visits. Maybe I would follow that even up with, what are your 2 most important questions today? Again, affirmations can be very helpful, but we don't want to overuse. Evoking change talk is about finding that ambivalence and bringing that back to the patient. When you hear a mixture of change talk and sustained talk, you know the patient is ambivalent, and that's not a bad place to be. I want to remind you again, bringing this slide up again, that this is not, even though this looks like stair-stepping, that these 4 processes are used interchangeably. So for example, at the beginning of my first contact with a patient, I'm going to work more on engaging. In fact, 70 to 75% of my first interaction with a patient might be all about engagement. But as I develop that partnership, I'm going to start to move up the stairs and start to put more focusing and evoking and planning as we get there, as the patient demonstrates their ability to move in that direction. But I can always go back down the stairs. So for example, that maybe had a patient that had a really hard day, I may go back to engaging because we're going to talk about that hard day. We're not ready to talk about planning for a health change when something else is happening and perhaps needs to be discussed first. There are reflections, and there are simple ones. There are very complicated reflections. I recommend we start with the simple. These are simple reflections, repeating an element of a statement the patient said, rephrasing something they said. These are the simple ones. They're the most easy to use when you're new to motivational interviewing, and the 4 communication techniques I'm going over today. Reflective sentence stems for those individuals that are doing a little bit of higher level, a bit of more involved reflection. You might hear something like, it sounds like you're wondering, you would like to see, that makes me think, if I understand you correctly. These are ways that you can lead into reflecting what the patient said. And what you're doing is you're listening. You're listening and looking for flowers among the weeds, as I say. You're looking for the things the patient can do. And you're focusing on those things the patient sees that they can do and working through that maze of weeds where they're uncomfortable or feeling that they can't do. Finally, at the end of your conversation or session, if you have a 15-minute session, you need to have 2 minutes on a summary. You need to summarize what just happened between the 2 of you, which then again validates to the patient that you were listening and paying attention, and it sets up the tone for future conversations, whether they're on the phone or in person at the clinic. Short 1 to 2 minutes, and you're basically saying to the patient, did I get it right? A summary might start with, let me stop and summarize what we just learned about. You're not sure that you want to be here today, and you really only came because your partner insisted on it. Again, you can read this slide as best as, as well, but here at the end I say, did I miss anything? I'm wondering what you make of all these things that I've just stated today. Again, giving that patient that last word too. 2 tools I want to share with you. Motivation. The 2 most important questions at the end of a session. If a patient has agreed or committed to making a change, I want to ask 2 important questions. On a scale of 1 to 10, how important is it for you to make this change? Because if it's not that important, the patient might not be ready this week to make that particular change. The second question, on a scale of 1 to 10, how confident are you that you'll be able to make this change? If a patient's only 2 on a scale of 10 in confidence, that would be another reason to sort of pull back on the reins and say, I'm concerned that your confidence is not as high. Would it not make sense to be a little more confident? What can we do together to help with that confidence? Or how did you get to 2? Because whatever you did there, that might be important to getting to 3. So again, different ways of using this tool. Case Western puts this particular tool together. There are rulers that you can actually put in your pocket, put it in a book, and pull them out and show the patient. I've also used a tape or a ruler I bring in with me to actually show the patient that we can measure it. And this is really great when you're trying to document in a patient know where the patient is. You've got some documentation of where the patient is in making a particular healthcare change. This is another wonderful tool, also by Case Western, and it is a lovely card that gives great recommendations and questions, reminding you, did I get it right as a provider? Did I listen enough? Did I ask open-ended questions? I hope that you will look and find these resources, because I have found them to be wonderful resources in the clinic setting. So in summary, knowing the basics about any chronic illness or an acute illness when you're working with individuals who have health care needs, communicating with patients in a way that honors their autonomy, their voice, their culture, everything about them. Be willing to suspend that authoritative, I know better than you, I have the information you don't, this is what you have to do. We want to suspend that, and we want to find out what it is the patient, what tools they already have, and how do we help them build new tools. Being willing to explore patient capacity rather than incapacity. Again, reframing and not judging. And then showing the patient you have general interest in their experience and their well-being. And lastly, I want to add, taking good care of you, making sure that you take breaks, because working in this line of work in helping people make change is very time-consuming, and you need time and breaks so that you can refresh your attitude, refresh your time, so that when you work with these patients, you feel committed and engaged. I'm set for questions. Thank you so much.
Thank you, Debbie. We do have one question already. How do you feel about motivating clients with gift cards or prizes? Does this have a place in the motivational interviewing process?
Wonderful question. Thank you for asking it. And yes and no, okay? I have some ambivalence, and I think as providers we need to know what the pros and cons of anything are. I've done a lot in working with prenatal classes and teaching adolescents how to care for themselves and the new addition to their lives. And we have to be careful when we motivate, because we can over-motivate. It's like overdoing anything. I usually reserve those types of gift cards and prizes to entities that are outside of my clinic office. I like other agencies to provide those resources. I like to tell my patients that those resources are available, but I really like to not use those in motivational interviewing unless it's about transportation, basic needs, getting somewhere, getting to the office. And the reason is because I want the patients to find internal motivation. And I let them know where that resource is. For example, in one clinic, there was a provider that was giving out baby clothes and wonderful things for patients that were in our program. But what happened was then everybody in the entire waiting room was wondering where all these things were coming from. And so what we did is some of the outreach workers would give coupons, and I came up with this coupon kind of thing where you get a coupon for coming to clinic and having a discussion about behavioral health change with me. And that coupon you took to another area of the facility, and you got to shop in that room, and there were baby clothes and baby things and pregnancy clothes and lots of fun things for new parents to access. But it was located outside the clinic walls. It was in part of the building that was not associated with the clinic itself. So again, just being sure, we want to be sure our patients are motivated internally, because those are the things and behaviors that will stick. If we are constantly using external motivators, we oftentimes will lose the health behavior, and the maintenance phase once those things are removed or no longer available. Thank you. Great question.
Okay, and here's a follow-up question to that, which is what happens with relapse? Do we start at the beginning of the process again?
That is a great question, and it depends on the patient. Not always. You'll find that you'll go through faster the second time. What I find myself doing, here's a good example. I had a patient call me from a hospital ICU because her husband had just had a heart attack, and she had just quit smoking a month ago and was in maintenance. She called me up and she said, I just smoked a cigarette. And I said, I'm on my way. And I said, while I'm driving in the car, think on something for me. How does you smoking the cigarette, how is that going to help your husband who's fighting for his life in the room? How does that help him? And when I got there and sat with her, she said, I'm so glad you asked that question. It doesn't help him at all because it's going to make me sick and then I won't be able to help him. She said, you asked me the right question. So I didn't have to go all the way to the beginning. She answered her own question for herself, and I just was there to ask the question.
Yes, indeed. Now, the same person that asked about the incentive program, I do want to mention her comment, which is that they have a reward program for small prizes for clients that achieve an undetectable viral load, and she says that it seems to work. And I know that some of these smaller incentive programs have worked really well, and I think that your point about evaluating exactly how you're doing it and who it's going to impact is really valuable.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.